everyone, and welcome to today's webinar. I'm Amy Guberman on behalf of Education for NAHC, the National Association for Home Care and Hospice. We have an exciting 60 minutes of education for you today, and we ask that you submit questions throughout it. To submit a question, simply click on the Q&A box on the bottom right side of your screen. Finally, within a business day, you will receive an email from NAHC with a link to access this recorded event. Today, we are honored to hear from Johns Hopkins for our fourth 2021 NAHC COVID-19 Town Hall webinar. I'd like to introduce Mary Gibbons-Myers, President and CEO of Johns Hopkins Home Care Group, Potomac Home Health Care, and Potomac Home Support, and Mary is Chair of the NAHC Board of Directors. Mary, I'm going to turn it over to you.
Thank you, Amy. It's a pleasure to be here. Before we get started, let me ask my colleagues to introduce themselves. Penny?
Good afternoon, everyone. My name is Penny Carey. I'm Executive Director for Home Medical Equipment and Respiratory Services, as well as the Administrator for Emergency Preparedness for Johns Hopkins Home Care Group.
Mitra?
Good afternoon. My name is Mitra Govgrani, and I'm Vice President for Pharmacy Services for Home and Community-Based part of the Johns Hopkins Medicine.
Dr. Kelen?
The Johns Hopkins Office of Critical Event Preparedness and Response, and my day job is to direct Johns Hopkins Medicine Emergency Department.
Thank you all for being here. A lot of people have been asking if Johns Hopkins is mandating vaccines. And as far as the COVID-19 vaccine, it's not mandatory at this time at Hopkins. It is voluntary and only given to those who wish to receive it. But I will say that the yearly influenza vaccine is mandatory for all employees, regardless of their position, unless they have a medical or religious exemption. I've also been asked if we're offering an incentive to vaccinate staff. And I would say that Hopkins is not offering a monetary incentive. It's the same way a lot of the businesses are right now. However, we do encourage our staff to get the vaccine. We offer an ability to receive it through our health system, which makes it a real easy scheduling system. And we also provide our employees up to 2 hours of paid time off if they're receiving the vaccine during work hours. Another benefit that we offer, if they have symptoms after receiving the vaccine, we give them, or they're eligible, up to 2 days of paid time off. That is in addition to their already scheduled time off. So it doesn't take away from their bank. So that's how we're encouraging it from a monetary process. Penny, as we move forward, can you share how we're dealing with the patients who are actually declining visits from our unvaccinated staff, or who are really only requesting to be seen by vaccinated staff?
Sure. We've had this happen to our home health staff. Our employees are not required to provide information on their vaccine status unless they choose to do so. We consider this obviously protected information under HIPAA. However, we know the situation is happening, and so we've worked in collaboration with the health system on scripting our employees and giving them a tool they can use if they are asked about their vaccination status by patients or the patient's family members. The Johns Hopkins Medicine statement at this time is the safety and well-being of Johns Hopkins Medicine's patients and staff members are a priority. While I, a clinician, prefer not to discuss any personal information, I can tell you that since December, Johns Hopkins Medicine has offered the FDA-authorized COVID-19 vaccine to all of our healthcare personnel who deliver care or who support the care of patients. To date, about 75% of Johns Hopkins Medicine personnel have been vaccinated. Even after staff members are vaccinated, we continue to practice safety precautions, including masking, physical distancing, and frequent hand washing. We also took this to our Patient and Family Advisory Council for input. We heard from that group that reminding our patients of our focus on the proper use of protective personal equipment and physical distancing and hand washing to keep everyone safe would really make them feel most comfortable when we enter their homes.
Penny, can you also share how we're addressing vaccine hesitancy, misinformation about the vaccine, and historical mistrust with the medical system with our workforce?
Yes, we've put a huge emphasis on communication to our employees. We know that there is a lot of inaccurate information and rumors floating about online and through other media. So it's critical that we provide our staff with a place to find correct, factual, and timely information. Some examples of how we've communicated with our workforce include quarterly town hall meetings, email communications that are clear, concise, and timely, articles and important updates in our monthly e-newsletter, printed and digital signage in our offices for those staff that remain office-based, an employee intranet site dedicated solely to COVID-19 information that has videos, frequently asked questions, and health and well-being resources. An employee call center where staff can ask our occupational health services team questions about the vaccine should one of those other tools not be adequate enough. We also have had a lot of really helpful information on the Johns Hopkins Medicine public-facing website. For example, we have a section dedicated to vaccine equity, which you're looking at right now. It describes a lot of the opportunities, not only the community stories, but learning resources, initiatives, and in the news. The community story you're seeing now is ensuring equitable. So we have from giving vaccines to the Baltimore City County School where we're located to different priorities throughout the health system and making sure that we launch for people with disabilities as well as equity issues. The next article we'd like to show you is several articles from Hopkins experts, such as this one on vaccine hesitancy and the 12 things that you need to know. This was written by our Chief Diversity Officer and has a lot of great information, and these websites will be shared with you after the presentation.
Thanks, Penny. Now that we've discussed how we're communicating about the vaccine, can you share some information on how our employees are scheduling their vaccines? Also, what the uptake has been really looks like.
Sure. We're using MyChart, the patient portal of Epic, which is our EMR for our system, to schedule vaccinations for our employees. Employees are first asked to activate their MyChart accounts to be able to request the vaccine. Once in MyChart and their account is activated, they complete a COVID-19 vaccine request form to determine their eligibility. They are put into a lottery selection process and provided a scheduling ticket when it is their turn. Upon receipt of that ticket, they'll be able to select from a variety of locations and times of their choice to receive the vaccine. This is an example of our dashboard. It looks like for our home and community-based services. And just to point out a few things, the top section is how many individuals out of our 1,260 have activated their MyChart, how many have not activated. And then the bottom section shows us where we move on vaccine survey response. So 85 have declined. You can see in the 1A prime, the 1A, 1B, 1C, 2A, and 2B, all of those percentages add up to the individuals that have been vaccinated, and then no response of 372, and 37 were not eligible at that time. Keep in mind that this only includes the individuals who have gotten vaccine through Johns Hopkins Medicine. We know that some employees have opted to receive the vaccine elsewhere, such as through their local health department, so those numbers are not reflected here as we are not tracking that information at this time.
Thanks, Penny. Mitra, I'd like to ask you some questions now. Can you give an example of a rumor about the serious side effects of the vaccine and how we've dealt with that at Johns Hopkins Medicine?
Sure. One of the rumors that come to mind was a concern that COVID-19 vaccine would affect fertility. Obviously, this is not true, but was understandably a concern for some employees who heard the rumor. To address this, information was added to the employee frequently asked questions on the COVID-19 internet that Penny mentioned earlier, and you see it on the screen, that response or the information that we provided. In addition, this same information was added to the public-facing website as well, so that's available for anyone from public who might be interested in answers to those questions from our experts as well.
Thanks, Mitra. One thing I do want to recommend to all of you listening, building that employee frequently asked questions domain is so helpful to our staff. That all the questions they have and all the concerns, whether you make these available on your internet site, through a newsletter, or even email, I really think it's really important, and we've heard really positive feedback about it. Mitra, let me ask you another question. Can you share a little bit about how we are administering the vaccines at Hopkins?
Yes, Johns Hopkins Medicine started employee vaccinations first in clinics back in December 2020. As a health system, we chose to take a systemic approach to distributing the vaccine, even though we have locations across the country in DC and Florida. We were still able to organize and systemically approach this. And it is not something that would have been possible on our own as a single entity or a home care organization without the support of the health system. And if you're not part of a larger health system, I would recommend you partner with a local health system or a pharmacy in your area for employee vaccination, as logistics and the equipment and infrastructure can be taxing. So many of our staff, including our nurses, our pharmacists, pharmacy technicians, our delivery team, and central supply and supply chain staff, played a critical role in vaccinating both our own staff as well as the patients in community through the community outreach efforts that Penny mentioned. Our HME team has continued to support transportation of the vaccine from a central storage area to our clinics throughout the week, and this requires a lot of logistics, and unless you're an expert in this field, which our HME distribution team is, it really is hard to learn these on the go. And our December 16 was a historic day for our home care team specifically, as well as Johns Hopkins Medicine and Broad, because it was the first day that we vaccinated the first employee, and one of our staff was the vaccinator. Our team of staff are continuing to work with our patients, along with other colleagues from Johns Hopkins Medicine, to help them sign up through MyChart and locate appropriate clinics in their community. Our home-based primary team is in the process of coordinating the best way to handle logistics of providing these vaccines to those homebound patients in our community. So I'd like at this point to take a minute to pause and share a video with you and indulge you in the joy of first day of vaccination effort in our health system. And I'd like to ask you that you come back and stay with us for after the video finishes, as Mary will engage Dr. Gabe Kelen in additional questions and answers.
So are you going to do the left arm or the right arm? I'll do the left arm. Ready? I still feel
I'm Kelly Casey, and I believe I received the first COVID-19 vaccine at Hopkins.
So today is the very first day that we are vaccinating people, and this is really incredibly exciting for all of us as we see employees come in here. Very quickly, we're going to be rolling out clinics at Sibley, Howard County General Hospital, Bayview Medical Center, and Suburban, and we will subsequently roll out additional availability as soon as we receive the vaccine supply.
So I'm Lauren Barber. I'm a pharmacist and a vaccinator here today. Today I gave the first vaccine, and it just really felt wonderful.
I decided to get the vaccine after seeing a lot of pain and suffering in our patients and our coworkers, being fearful of taking it home to my family. It's the first time I've had hope in a long time.
I'm Jacob, and the reason I got my vaccine today is because I just want to be able to protect myself so that I can be part of the solution and continue to work and take care of the patients and avoid getting sick.
So this was really a monumental effort from so many teams to be able to pull this together today. This included supply chain, pharmacy, central supply, health IT folks from Epic, as well as ambulatory and all of our occupational health teams working together as one system, as one team, and as one unit to be able to pull this day off together. And so we're incredibly proud of the work that so many people have done to make this happen today. And this is really a big win for all of us.
Countless hours have gone into preparing for this moment. I couldn't be prouder of the team, especially the ability that we demonstrated in collaborating with pharmacy, occupational health, our clinical and operational leaders, and pulling together the specifics and the nuances around how to create cold chain storage for a vaccine that needs to be kept at -70 degrees Celsius.
So that's 975 doses. It's our first phase 0 wave of vaccine supply. This team has been great, and it's been great to be a part of the broader response team in order to help protect our clinicians and serve the Baltimore area.
My name is Chauncey King, and I'm a paramedic with Johns Hopkins Lifeline Critical Care Transport Team. And we're here today at the clinic to provide emergency assistance just in case someone has an anaphylactic reaction or some sort of allergic reaction, or just not even feeling well and may need to go to the emergency department.
This has been a really tough time, and I know this is a skill set that I have to offer, and so I was just happy to volunteer to provide those skills today.
I am feeling hopeful. I can't wait to see it get to the general public. I know it's going to take a little while, but it feels like a very good first step. I'm excited to be part of it.
Absolutely. I definitely have hope now.
Thank you, Mitra and Penny. I want to switch gears a little bit now and ask Dr. Kelen, as a national expert, some questions about the vaccine. So, Dr. Kelen, now that we have 3 vaccines that have been approved by the FDA for emergency use authorization, Pfizer, Moderna, and Johnson & Johnson, how do we know these vaccines are safe?
Thank you, Mary. Let me just give a very brief primer that will help explain the safety of these vaccines. The Moderna and Pfizer are what are called these mRNA vaccines. The Johnson & Johnson and the AstraZeneca use adenovirus vectors and have genetic material piggybacked on top of them. There's others around the world that we are not using here in the U.S. This mRNA vaccine is so simple, so brilliant, so elegant that it's worth showing. It's a story, like there's like message in a bottle. So there's a little piece of messenger RNA that gets wrapped around a little bubble of fat, and that's what gets injected into you. It gets taken up by the cell, and there's a little guy in the ribosome that reads the message. And the message says, hey, make all these little spike protein looking things that are the exact same as on the outside of the virus, and then spit them out. And so the cell makes these little spike protein equivalents, spits them out, and a bunch of different cells pick them up, and your immune system goes into action and then forms memory as to how to attack these in the future. The Johnson & Johnson and the AstraZeneca are, as I mentioned, a modified virus, a common cold virus that cannot replicate and it cannot infect you. It gets injected, it goes into the cell, it's DNA-based, and it makes an mRNA, and the rest of the story is very, very similar. The message RNA gets read and makes these little spike protein-like things that the immune system then recognizes, kills, and then in the future knows that that's what it should be attacking. Now, when it comes to safety, at this point we're about a year out from people who are in the trials for both types of vaccine. And the trials are actually followed up to 2 years for side effects, but the vast majority of people with any kind of reaction are going to be almost immediate or within days. And after 40 days, it's actually extremely rare to have any kind of side effects, serious or not. In the studies, the difference between those that got the vaccine and those that didn't with immediate side effects were absolutely no difference at all. And when you looked at serious side effects, they were things that couldn't reasonably be considered as vaccine-related. Heart arrhythmia is the same in both groups. Pneumonia, heart attack, appendicitis, that's not reasonable to consider as vaccine-related. There was concern that this mRNA is such new technology that, oh, gee, do I really want this? But it's actually been years in the making, and there have been many other studies that have used it, but there just hasn't been a good pandemic in which to give it to masses of people. The mRNA is very unstable. It doesn't combine with your DNA or anything else. Once it's read, it disintegrates, and quite frankly, quite a bit of it disintegrates even before that. So in and of itself, for those of you who are worried that it combines and may alter your genetics, it doesn't. It doesn't stay around long enough to cause other autoimmune type of reactions that people have generally been afraid of. One condition that you had probably heard about is this thing of Bell's palsy, where a major facial nerve, it's the seventh nerve, is paralyzed, and originally it was seen to be somewhat higher in the vaccine group. That has not borne out, and it has not been in any higher rates than in the general population, possibly even less. The other condition that people are very, very afraid of is Guillain-Barré, because there was a pandemic outbreak in 1976 on an army base. They rushed a vaccine into production, and quite a few people got Guillain-Barré. Since then, with all the influenza vaccines and other related vaccines, there have been very few Guillain-Barré cases. People who got the flu vaccine actually have lower rates of Guillain-Barré, and we have not seen Guillain-Barré thus far, as best as I know, in any of the vaccines. I think it was mentioned, this myth about fertility, and that was because this protein, syncytin-1, is a spike protein, and so people thought, oh, spike protein, the vaccine must attack spike protein, but it's a completely different composition, and the immune system does not recognize it as attackable. So obviously we can't tell you that it's safe forever and ever and ever, but 100 million people in the U.S. and something close to that in the rest of the world have now been vaccinated with the various vaccines, and significant serious side effects have been extremely few. I think you're muted.
Thank you, Dr. Kelen. Knowing this about all the various vaccines, how should people know which one to choose?
The short answer is don't bother to choose, and I'll show you why. So here's Pfizer, Moderna, and J&J. I have the others mapped out too. So the way they're handled is a little bit different. J&J is easier handled, but the efficacy looks a little bit less for J&J, but when Pfizer and Moderna did their studies, all these variants weren't around. And even for severe disease, J&J is very effective. And for all of them, no deaths, no ICUs, no serious disease. I mean, there's not a lot to choose between them. Some people may like J&J because you're only getting one shot, so the chance of a side effect from the second shot obviously are a lot less, and it's very convenient. You have to show up once, you get your shot, and you're essentially done with. My advice is if you're offered a vaccine, take it.
Okay. Thank you. So the next thing is, this is the big question, is it still possible to contract or spread COVID-19 after being vaccinated?
So we don't really know, is the truth. However, there's lots of evidence now that the amount of virus that you might be able to harbor once you are immune is significantly less and may not be enough for you to vaccinate others. But do remember that when you're vaccinated and you have immunity, it prevents disease from taking hold in your body. It doesn't necessarily prevent you from hosting as a carrier state virus. But either way, the data certainly seems like even if you have some virus in and around you, it's significantly less if you're vaccinated than if you're not.
Thank you. There's been a lot of discussion about the variants of the current coronavirus, and I believe most common in the United States is the B.1.1.7 or the UK variant. Do the vaccine protect against these variants?
So they actually do, except for AstraZeneca, which we're not using. In South Africa, it was very, very poor against the South African variant. The most common now in the U.S. is this B.1.1.7, which is the UK variant. We're somewhere around 50% of the infections are now this, and that's one of the reasons we're now seeing a significant uptick, apart from everybody relaxing what they're doing. But Pfizer, Moderna, and J&J show pretty reasonable effectiveness. Again, you may get some symptoms, but no hospitalization, no ICU, no intubation, no deaths. I mean, that's a pretty good deal. I think most of us, if we got a mild cold, we would take that if that's all we had. We just want to make sure that we're not going to end up in hospital and permanently disabled. I'm just going to quickly show you what the issue is. That purple grape-like structure is the spike protein attached to the receptacle on the human cell, and that is sticky. But in the native virus, the original one, it constantly binds, unbinds. It's not very sticky. But in the UK and the South African and these other variants, it's very sticky, and that's why it's more infectious. As to whether it's actually more deadly is still somewhat of a debate. Probably not, but a lot more people are getting infected with it.
Okay, thank you. Do we know yet if people will need to get vaccinated again or receive a booster? And do you believe this is going to become a yearly vaccination, just like the flu shot?
Yeah, I'm pretty sure it's going to become a yearly vaccine. Immunity, the science keeps showing it lasts longer and longer. So now we're up to about 8 months proof that immunity lasts that long. It's probably a good year. But all science points to that variants are ultimately going to take hold, and we're going to need boosters, just like with flu vaccine, to account for the variation. And so probably each year, sometime in the fall, we will be getting either new vaccine or booster vaccine. So it's almost inevitable.
Thank you. And we know it's important that people continue to wear masks, continue the social distancing, practicing the hand hygiene, even after being vaccinated. How much longer do you think these precautions are going to be necessary?
So that depends on when we reach herd immunity, and it's proven more significantly that if you're vaccinated, you're not going to be able to carry the virus and give it to someone who isn't. We're up to about 2 million first doses of vaccine a day, and herd immunity is actually pretty close, especially in the adult population. So there's about 250 million adults in the U.S. above age of 18, and to reach quite a significant number, 80%, and that's on the upper limit of what people consider herd immunity. So we need about 200 million people who are immune. We've already started, 100 million people already gotten their first dose, but people have hidden immunity. So in blood donors who have not yet been vaccinated, 20% show evidence of having antibodies to COVID-19. So of those not yet vaccinated, that's about 20 million. There's 20 million adults, roughly, who've been infected. So if we could test for that, we'd actually have about 60 million people left to go. But let's say we have 100 million adults. At 2 million a day, that's like 50 days for everyone to get a first dose. Add another 42 days on the outside if somebody gets Moderna. So we're looking at less than 3 months, as long as there isn't significant hesitancy, at least among adults. Children is a whole other ball game, and you probably heard earlier this morning that Pfizer and Moderna appear to be pretty effective in the youth adolescent group, that 12 to 16 years of age. So that's very, very good news for kids being able to get back to school. But it's also thought that as long as there's herd immunity among adults, kids can go back to school as well, even if they're not fully vaccinated.
Great. So it looks like there's a light at the end of the tunnel.
Yeah. But in the meanwhile, wear your mask, do reasonable social distancing. The CDC has issued guidelines under what circumstances you can get together with other vaccinated people and being able to hug grandchildren and so forth if you have them. But don't go too nuts yet.
So share us your thoughts or your predictions of where you think we're headed with the COVID-19 based on everything you've said right now.
Yeah, so we're in the middle of a surge right now. And obviously people have let down their guard. If you're like me, you send out an email and about a third of them come back, I'm out of the office. So a lot of people are out there partying or vacationing and traveling regardless. So we're in the midst of a surge, and that's going to last at least a month before it starts to come down and trail. So again, I think until about 2.5, 3 months, when a more significant part of the population is vaccinated, we're going to be, COVID is still going to be an issue, and it's a battle of time against whether the variants take hold. One piece of very good news is among people age 65 and older in the U.S., something like 72-73% have already received their first shot, and half of those are fully vaccinated. So, you know, the elderly and very vulnerable people that are at least related to age already have a very strong foothold. So that's very good news.
Very good. Thank you. Amy, before I go forward, do you have any questions from the panelists?
Yes, there have been some great questions that have come in. Dr. Kelen, is there a study you can point us to share with our staff regarding a successful mRNA vaccine prior to COVID? We are experiencing trust issues since the PCR test cycles were drastically reduced and the subsequent reduction of COVID-19 diagnoses.
Yeah, I don't have them at my fingertips, but mRNA vaccines were used in preparation for things like Ebola and Zika outbreaks and so forth. And again, they just didn't really have to go into mass production. Historically, and you know, the history of vaccination, including with attenuated live virus and DNA and all sorts of stuff, is pretty long now. And when you have like tens of millions, even hundreds of millions of people having received shots, and knowing that the vast majority of serious, including immunologic reactions, are going to present themselves very early, certainly within the first month and a half, we just have not seen that. Obviously, you have to make your own decisions. We have a fair amount of data about pregnancy as well, but there are people who still wonder about that too, and people have to make their own decision. But if I could share my screen one more time, I'm going to show you something. Can you turn the share on? Oh, yeah, there we go. Okay. Let me get back to this. I'm going to show you one more thing. I'm going to skip this, but here's what I want to show you. So these are the case fatality rates, whether you know you're infected or not. That's on the left, and if you are symptomatic on the right. These are like real numbers, and these are people who die and continue to die in these age and risk groups. And so I ran some numbers here, and if you're worried about like these long-term effects, the likelihood of dying from COVID, not even considering whether you have comorbid conditions or not, even at the age of 15 to 19, is about 1 in 40,000 if today you're not vaccinated, and you're assuming that maybe half the population is. The likelihood of a long-term impact, if you're unvaccinated, of something in your health, I mean, if you're over 50, that's like 1 in 20. I mean, that's an astounding number. And even for a younger age group, it's still 1 in 200. I wouldn't want to be that. But vaccine-related adverse events, we're not seeing anything that can stick out as higher than what might happen generally in the population. So I get it personally and had it myself. But the mRNA hadn't really been done in large numbers. And adenovirus, yeah, I guess we have had a lot of experience with that. But these numbers to me are what are scary. I'll take my chances from a vaccine.
Thank you. We have another question. Could you speak to people who have autoimmune diseases and safety with vaccines?
Me personally, sure. We have been vaccinating people with autoimmune diseases and people who have compromised immunity. Autoimmune diseases do not seem to be peaked, meaning do not seem to be threatened or augmented for people who get vaccines. Even people who have allergies, that does not seem to be stressed. And even people who have anaphylaxis to various substances will not necessarily, in fact, are not particularly likely to get anaphylaxis from this vaccine. We have seen a few cases of it. Fortunately, because of the way the clinics are set up, not just with us, but throughout the whole United States. A little bit of epinephrine, a quick trip to the ED if you need it, and so far, knock on wood, everybody has been fine. The one issue with those who are immunocompromised, there's some evidence that the vaccine obviously is not as effective. It doesn't take as hold as easily because the immune system can't rise to the occasion as easily in people whose immune systems are intact.
Thank you, and I guess this question will go to the group. If you've had the infection, how do you know your immune status? Is an infection as effective at building immunity as the vaccine?
Dr. Kelen, I'll let you take that one as well.
Sure. The short answer is yes. Natural infection is pretty effective at building immunity. It is thought by some leaders, although we can't outright prove it, that in this case, some of the vaccines may offer even stronger and more durable immunity. That's not the case with every type of vaccination, but some people think it is with this one. So as I mentioned, right now we're out to about 8 months or so, either way, a natural infection or vaccine. It's probably actually even longer because our immune systems tend to go to sleep and seemingly are non-detectable levels of things like antibodies. But then when you get exposed, they kind of wake up. It's called an anamnestic response. If you want to know, if you're like really, really interested, not that you need to be, unless maybe you do have immune deficiency, you can get tested for antibodies and to see if you can even get them titered out if you really, really want to see how boisterous your particular response is at a given time.
Thank you. The next question. If it is expected that a vaccinated person may carry the virus, but at lower levels, how common is it that vaccinated employees who are regularly tested, such as those at nursing homes and home care personnel, how common is it that they test positive?
You mean positive for virus?
Yes.
Yeah, you mean being infected. So I don't have that data. I do have some data among our own healthcare personnel. And we do have a small number of personnel who got infected between their first and second doses of Pfizer. Obviously, we wouldn't know how many might have had silent infections between first and second doses. And I believe we've had only a sporadic number of cases at best, like less than a handful of people who got infected, who are healthcare workers in our system, after the 2 weeks following either Pfizer or Moderna. It's been pretty rare. But remember, it's not like it's 100% pretty good at thus far presenting severe disease. It's probably, like 99 point something or other. But so it doesn't mean you can't get infected. Even in the trials, some people had symptomatic disease. So when you see these numbers of 90, 95%, 72%, it's not perfect at preventing some type of symptomatic disease. So whether you can transmit it better, we don't know. We do know that if you are symptomatic, it's less severe either way than if you weren't vaccinated.
Thank you. The next question. In plain language, why do people who receive the second dose tend to feel ill?
That's you again, Gabe, but you got to use plain language.
Have I talked plainly thus far? Or is that a hint? All right, so you get your first shot, you don't have any immunity. There's some local soreness anyway. Then you build immunity, and there you go, 3 or 4 weeks later, you get the second shot. Your immune system is already geared up, looking for these bad little parts of the virus, and your cells start making that type of protein, and your immune system starts to attack it. And so it attacks these new particles wherever it finds it, and it might be in your muscle, so you get a little bit of fever, maybe chills. It's almost like when your immune system goes to work battling anything. The good news is, for the vast majority of people, it tends to come on fairly suddenly, and then like 8-12 hours later, they're just fine. Like it just goes away, gobbles up the last piece of protein, we're done, and it goes away. So I hope that was plain enough.
That was great. Next question, is there any data information on immunosuppressed, compromised individuals and vaccine efficacy?
Yeah, I had mentioned earlier, I feel like I'm hogging the floor here, but I had mentioned earlier that there is data that the uptake is not as strong, and in fact can be quite weak among those who are truly immunocompromised. Not a big surprise, right? Your immune system is not in a situation to respond as normally as those who don't have a reason to have their immunity suppressed or muted otherwise. So yeah, there is data to that effect.
Next question, do we know what types of ADRs are being nationally reported to, forgive me, I don't know this acronym, VAERS yet? VAERS? Shouldn't these be accounted for in the safety profiles of these vaccines?
Gabe, I'm giving you that again because I don't know.
Yeah, so this is the anonymous reporting system, and anybody can report anything that they feel is part of, if they have any kind of symptom or concern that might be related to the vaccine that they received at any point. And it is monitored continuously for little blips that seem untoward and are not consistent with just things that might happen in the normal population, and then it's investigated. Thus far, the types of things are not unexpected. There's a lot of sore arms, there's a lot of fever, there's a lot of chills, being maybe the 3 biggest. Obviously, people have reported allergic reactions, which come in a number of ways. I mentioned anaphylaxis. That's sort of the, in my mind, the worst of the worst. That's sort of the end pathway. But people have gotten rashes on the arm that was infected. People have gotten just urticaria, hives on the side of their body that got injected. Some people, their lymph nodes in the armpit area, sometimes even in the breast, on the side that got injected become inflamed for a while. And you probably read articles on trying to avoid getting mammograms in the immediate period after, because it may be misread as having a lump when it's just a reactive lymph node. Those are the major things that have been reported. As I mentioned, the biggies like Guillain-Barré and facial paralysis, transverse myelitis, and the kind of things that we really fear have not been reported much. There have been incidental heart attacks, but when those are investigated, they really truly seem coincidentally incidental to receiving the vaccine, as opposed to caused by some arrhythmia or something weird caused by the vaccine. And it wouldn't make an awful lot of sense as to how the vaccine itself would cause a heart attack.
I have a follow-up question from the same person. Have there been any clotting side effects to report, like DVT or strokes?
So as you know, with AstraZeneca, people got very concerned because there were a number of DVTs, pulmonary emboli, and some hemorrhagic strokes as well, when people had decreased platelets, so the clotting was consumed and not very good. The vast majority of people who had these DVTs and PEs were women under the age of 55. While it's still being investigated, from a population point of view, the number of people who got AstraZeneca and had clotting issues is actually less than might be expected generally in the population. And one thing that is unclear, we know that oral contraceptives are associated with clotting issues, and I don't know how well thus far it's been investigated as to whether the population, again, mostly women under 55, who had these events were also on oral contraceptive or not. When the European various health agencies looked at this clotting issue, they deemed that again, it was either the same or less than might have otherwise been expected in the population, and then reinstituted the use of AstraZeneca.
Dr. Kelen, for our next question, when, how will the decision be made to administer a third booster or annual vaccine?
So the decision will be based likely, I don't actually have a crystal ball, but it'll likely be based on two things. The studies that look at the attenuation of the vaccine impact. So as I say, right now it looks like a good 6-8 months, maybe even longer, probably is longer. And if we start seeing incremental blips of infections among people previously vaccinated, or the variation, like even bigger mutations than we are currently experiencing, come to fold. The other nice thing about the mRNA technology is it can flip on a dime. In 6 weeks, they can manufacture a new vaccine to whatever is going on around the world. Whereas you take a look at flu, the technology that has long been used there is trying to guess what the mutations are going to be, and then 6 months of very heavy-duty lab work to make the vaccine equivalent to what was thought of 6 months before that. And a year goes by, and then sometimes the flu vaccine just isn't that effective because the mutation actually went in a whole other direction.
So Amy, is that all the questions?
Oh, we just had one more come in, and then we will begin to wrap up.
Okay.
What is the difference between mechanism of action between AstraZeneca versus Moderna, Pfizer? I acknowledge that J&J is a viral vector, I'm curious why Astra vaccine had the clotting side effects that Moderna, Pfizer did not.
Yeah, I have to say I don't have any particular insight into that, and I don't even really venture a guess. It's a slightly different virus. It's still an adenovirus, and it's a slightly different DNA composition, although they're obviously very, very closely related. And the related question is, why was AstraZeneca so lousy against the South African variant, whereas J&J using the same technology was pretty good. They also used different doses and different concentrations, so truly couldn't tell you.
Thank you, Gabe. I'm going to ask one last question. I think someone was trying to get at, if you've had the infection, should you still get the vaccine?
Current recommendation is yes. You will almost for sure get side effects because your body's pretty ramped up. Oh, by the way, I should mention, if you get a second shot, it's just part of your routine vaccination, and you don't have much in the way of side effects, and some people don't, it doesn't mean that the immunity is not taking hold. So the strength of the reaction that you get doesn't mean you're like really, really immune. And if you get zero, it didn't take. You know, if you can delay, you don't have to delay, mind you. You get it when you get it. You know, 3-4 weeks later, after your symptoms have died down and you're not febrile and you no longer test positive, you know, all those types of things. When vaccine was scarce, and to some extent it still is, if you feel it fair to wait 3 months, that's not unreasonable, because you're reasonably immune at least to 3 months, and this is almost like your booster.
So thank you, Dr. Kelen, for sharing your knowledge and expertise with us today. I know we gave you a lot more questions than we were planning, but thank you. I do want to end today's town hall by acknowledging the strength and resilience of everyone that's shown up on this call and over the past year. And one thing I wanted to do is share a video with you of a poem that was written by a Johns Hopkins employee that's called March. It just really kind of pulls it all together for us. It's very touching. And before I close, before the video, I just want to remind everybody just to remember, there's no place like home care. Thank you, everybody, for being here. He gets it, everybody. Okay, wait for the video. I think you'll really enjoy it.
March. Just as spring nudges against us once again, and the sunlight rests on broken winter trees, not brittle, but ready, and we begin to yield to the hope of brighter days, ignoring just for a moment the sirens in the distance and the discarded masks shuffling along empty streets, and even, once inside, the stark hospital halls and the stubborn beeps. We know it's okay to take a moment, to be silent, to remember. It's okay to know that we are resilient, even as we stand stunned over the heartbreaking loss and the breathtaking recovery. The sliding away of an entire year, the sliding into another year, alone and together, through windows and across halls, bodies hooded and gowned, faces covered and turned. This is love in a pandemic. The eyes that had to smile for us because masks muted our mouths, the screens that said, goodbye, I love you, I'll see you again, the gloves that held our hands, not hands, but still heavy with hope and comfort. March said, I'm ripping away the life you knew, entering like a lion and roaring through the rest of the year. Somehow we held fast against furious winds, losing and gaining friends, patients, neighbors, colleagues, long months of data and doubt, stats and stubbornness, work and worry, yes, and grief and relief and guilt and pride climbing through us like vines or veins. And now, today, we remember we were there. We marched, we gave, we prayed, we loved through a year that lasted so long, it's still here. We're still here, now commemorating an anniversary we want to forget. This March, we know it's love that moves us. The naked oaks will start to re-leaf, the yellow crocuses to push through, and having rested for a moment, having reflected on the surreal, we'll stand and stretch with eyes open and hearts unmasked. We'll keep moving forward together to heal.